Okay, well, Herd, welcome to another news roundup. How you doing?
I'm doing good, man. There's so much news out there, so much happening. I feel like we're trying to keep this brief, but man, we could have 50 stories if we wanted to.
Well, we could go and go and go, but today
Yeah,
we're going to
there's just
focus on
lots
six.
happening in the world.
No, there's a lot, and we're going to focus on six stories that we're kind of smushing into about four. And so let's get going. So the first one is a story on from Medical Economics. It says the federal residency funding expands primary care pipeline, study finds. And so heard my interpretation of the story is it's interesting. It doesn't necessarily solve the problem of the top of the funnel, that there are not enough caregivers at the top of the funnel to get through the education process to meet our resource needs. But it looks like the federal government is responding. And under the ACA, the Affordable Care Act, they are trying to redistribute residency slots, and whether it is in excess spots in critical access areas or for closed hospitals, they're trying to get those slots and then put them in the right spots. So at least it's the right direction, right, Herb?
Yeah, I mean, we continue to see shortages of physicians, especially primary care in certain areas. I think we want to focus on access to care. We want to focus on making sure that we have the next generation of physicians that are going to be there to serve. And so I think actions like this address a true need.
Yeah, it's going the right direction. And so stories 2, 3, and 4 are all right there together. And it's about if we've got waste in the system, how are we going to get some of that waste out? And it's really interesting to me. Some of it can be seen as sad, but I see it as, okay, well, let's trim down to what we can. So the second is around HHS announced a sweeping reorganization, including cuts of 10,000 workers. This was a story on March 27th in Healthcare Dive. And it's talking about how their HHS is with RFK Jr. is cutting another 10,000. They already have had 10,000 leave. And so what you and I just found out is that's taken the HHS workforce from 82,000 people to 62,000 people. 10,000, I think, were voluntary departures. And now this is more of a forced 10,000. They're going from 28 regional offices down to 15. They are 28 departments to 15 and 10 regional offices down to 5. And that's going to save us somewhere around $1.8 billion. What do you think about that, Herd?
This is kind of in line with what we've been seeing with just the reorganization of departments, the removal of whole departments. We're seeing a lot of activity from the Trump administration. I think the key here is, we still have 62,000 people as a part of HHS, and can they still fulfill their mission in a way that's more cost effective and more efficient? I think that remains to be seen.
Well, and you said that, the key point here is it's not impacting Medicare and Medicaid services.
Yes. So that was called out in the story. And so this is, impacting, other areas besides that. And so, again, I think if they can fulfill the promise of, more efficient government, great. But again, we need to see, are they truly trimming things that won't affect services, won't affect the way HHS fulfills its mission? I think that's kind of the jury's out. We'll find out.
So interesting story. I just got back from ACHE Congress last week in Houston, and a lot of the nation's healthcare leaders come together for a week, and it was fascinating. I was walking with the CEO of the Tampa VA. Very interesting man, lovely man, incredibly smart. And I asked him about all this DOGE activity, and one in particular, I said, what about that's kind of a joke, right? The Elon Musk noon Monday emails, right? And he's like, oh no, that is very real. All of us have to do it every week. And now we're using it as an opportunity to find the best practices in the VA healthcare system. And they're celebrating some of these really awesome things that are coming out of these name 5 things you did last week, which I thought was pretty cool. So even though it can come across as kind of a dark way to root out, waste, they're using it for the good of highlighting really, really cool things that are happening. I just thought that was so cool, right?
Interesting. Yeah.
Yeah. So, okay. Third story is around taxpayers spending billions covering the same Medicaid patients twice. Now, this is, you and I spend the majority of our time taking care of providers, healthcare providers. This is the payers saying, yeah, it's kind of the state's problem if they have them 2 or 3 times in the state Medicaid rolls and they're just paying me for it. That's kind of on the state, right? I mean, that's terrible, right, Herd?
Yeah, I think if this is the right hand didn't know what the left hand's doing, and you have people that are on the rolls in 2 different states, and people getting payments for that, I think that's an easy fix, right? We're in this time trying to do more with less,
Yeah.
and so certainly need to be on top of it. So interesting story.
It didn't feel like it was sad for the payers, like they're just like, so we get checks, anyway, that's it. Now I don't know how that's going to get fixed. It didn't look like there was an immediate solution, but this was a Wall Street Journal article on 3/26 for anybody that wants to go read it. Fantastic story. The fourth story is really a more federal kind of clawbacks, and this is DOGE. So this is Elon Musk and DOGE and the CDC clawing back $11 billion in COVID grants nationwide. Herd, it was interesting. Back in COVID, there was, trillions of dollars, it felt like, just flowing in to the U.S. economy in particular, and a lot in healthcare. There probably was some fraudulent activity that occurred during that. And it looks like this is targeting, let's get at least 11.4 billion back in what was inappropriately spent during that time.
Yeah, I think, that was certainly an unprecedented time. And the charge at the time was, let's keep liquidity in the economy. Let's make sure our healthcare providers don't fail. Let's just, literally they were just dropping money into bank accounts without even being asked to do so.
Yeah.
And it was, again, unprecedented time. So right. Unprecedented response to something that, at least in most people's lifetime, we hadn't gone through something like that. So I'm not surprised to see this. We're kind of, the worm has turned, so to speak, and now we're trying to do more with less, trying to be more efficient. And so I think part of the DOGE activity is examining contracts, examining grants, and trying to, ones that aren't needed, we need to do something about. So this is right along the lines of what we've been seeing.
Okay, 2 more stories, Herd. The next one is a little troubling, where I can say it's too early to tell just quite yet. But this one is really a Fierce Healthcare and March 25th article. It says early evaluation of AI scribes finds decreased burnout but limited financial return on investment. And so to me, Herd, it feels like it's too early. One thing that I heard last week at ACHE Congress was every presentation was about AI and ambient AI in particular. And if you're not, exploring options and uses, you need to. And so it just seems like this one, the early evaluation of these AI scribes, and that's that ambient AI where it's listening and then making notes for the docs, and then not as the kind of the approved, medical record, but it's teeing it up so the docs can evaluate that and not have to all type it in and key it in themselves. To me, it really frees the doc to have more patient engagement, eye contact, less clicks on the computer. And I think the jury's still out. It's a little too early, it feels like to me, because to me, it's going to be a satisfier for the doc. It's going to decrease burnout. And I do think there's a financial return on this. It just feels a little early.
Yeah, I agree. And I think the frame of this story is more, do these systems allow you to code more accurately, to have, I guess, better charge capture, to use
and more throughput, more patients. It shows, well, you don't really get more patients.
And then potentially more throughput. So I think, I think it's too early to tell. I mean, this is brand new technology. And so it's going to take a little bit just to understand how to use it. And then as time goes on, as one, the technology should improve. 2, costs of that technology should go down as it gets more widely adopted. And then 3, processes it will potentially adapt to it. And so I think we're in the very, very, very beginning stages of all that. So I think there's a lot of promise there, and the jury's still out.
Yeah. Okay. Last story. This one's interesting because I've worked with a lot of physician-owned hospitals before, and this says CMS issues guidance on relocation of physician-owned hospitals. This is not a new precedent. I've seen this happen before. You remember there were a lot of physician-owned hospitals that were developed pre-2007 before the moratorium on physician-owned hospitals came about. And now you have this provision in the Stark Law that's the whole hospital exception. Well, those grandfathered hospitals have been out there a long time. And now this one, there was one case that just came up where they said, hey, we're going to relocate this over to this area, but we still want that to be grandfathered in. We're good, right? CMS said, yeah, you're good. And it still meets the whole hospital exception. That's important because there are a number, hundreds and hundreds of physician-owned hospitals out there that now in 2025 are aging facilities, and you may want to relocate those, but still have that unique hospital ownership structure. This says that provided you meet all the requirements still and ongoing, you can do that. I just thought it was pretty interesting.
Yeah, I mean, having that exception is obviously key, and it's pretty valuable to be able to have that and be grandfathered in to be able to have this physician-owned, exception. I think what this does, it allows some flexibility. Like you mentioned, facilities could be aging. There could be strategic reasons to move, and this gives you a little bit of leeway. If the decision had gone the other way, that would have restricted movement and potential relocation and kind of restricted people's options. So I think this was a positive in giving these facilities a little bit of flexibility for strategic reasons.
Yeah, it does not take away the argument that, call it the AHA, has against physician ownership of hospitals. That argument has been out there for a long time and will continue. But this at least allows, if you need to relocate a facility, you certainly can. So, okay, well, those are our stories today. Heard any parting comments?
No, lots of good stuff. There's lots of activity in the news every day. Healthcare is moving all the time, and so we're here trying to stay on top of it.
Yep. Okay. Thank y'all for listening. See you later.